Good day, I am Anna Nolte, and today we are going to do the third lesson in this series of the partograph. And in this lesson, we're specifically going to look at the contractions and the maternal condition part of the partograph. Now, when we look at the contractions, and this is now the part of where the contractions are being recorded on the partograph being enlarged, we look at two aspects of the contractions. We first of all look at the duration of the contractions, and we look at the normal frequency of the contractions. So when we look at the duration of the contractions, you will see that there's a scale or a key on the partograph normally to give you an indication on how to record the contractions. If the contractions are short and they are less than 20 seconds long, we only make dots in the block. When it's between 20 and 40 seconds long, we make diagonal line stripes, and when it's longer than 40 seconds long, we color the block. And when we look now at the frequency of the contractions, we see here these numbers from 1 to 5, and that represents the frequency of the contraction. So if there's one contraction in 10 minutes, that's less than 20 seconds, for example, we will make dots in one block. If there's, for example, 3 contractions in 10 minutes, between 20 and 40 seconds long, we will color 3 blocks with diagonal stripes to indicate that there are 3 contractions in 10 minutes. That's about 20 to 40 seconds long. Now, during the latent phase of labor, we assess the contractions 2 hourly, and during the active phase of labor, we do it half hourly. And here is the indication of how I've set the key that we are using. Here you can see there were 2 contractions in 10 minutes that was less than 20 seconds long. Here is 3 contractions in 10 minutes that's between 20 and 40 seconds long. And here you can see 4 contractions in 10 minutes that's all longer than 40 seconds. Now, some of the partographs, there's also a place where we can record the oxytocin if a patient has been on an induction of labor, or whether when labor has been augmented with oxytocin. And it's actually very important for this to also be on the partograph, because as we've said with the partograph, at one glance one can exactly see what's going on. We can see how much oxytocin the patient is getting, how the progress of labor is progressing, what the contractions look, etc. So here on this part of the partograph, we will record the units of oxytocin. That's now, for example, if 5 units or 2 units or whatever has been added to a vacuoliter of a liter, Ringer's lactate or whatever it's been put in. And then here will the rate of how fast it runs will be recorded here. And what is, as I've said, very important is to check the oxytocin in relation to the contractions, but also to the progress of labor. For example, if we see that these hypertonic contractions means there are more than 5 contractions in 10 minutes, we can immediately see it here. And we know that that definitely has an influence on labor and specifically on the fetal condition. Then there's this part of the partograph, which is, remember we've said the partograph usually goes over 2 pages. On the one page, we have done now the progress of labor and the contractions and the fetal condition. And on this part of the partograph, on this part of the next page, is the maternal condition and the different medications that we are giving them. When we look at the maternal conditions, and here you can see again a little bit of an enlargement of the maternal conditions, we look at the blood pressure, the maternal pulse, the respiration, the temperature, and the urine. And these all place for them to be recorded, which I will come into more detail and depth just now. The intervals with when we are supposed to record it differ, as we all know by now, from whether the patient is in the latent phase of labor or in the active phase of labor. During the latent phase of labor, all of these aspects, maternal aspects, if I can call it like that, will be recorded 4 hourly. The temperature, the heart rate, the respiratory rate, and the blood pressure will be recorded 4 hourly. But when we come to the active phase, the heart rate, the blood pressure, and the respiratory rate, so we can basically group them under the maternal vitals, will be recorded hourly. The temperature will be recorded 4 hourly, and the urine whenever the urine is being passed. And we will come to again when we talk about the 4 Ps, and we will see that it's very important that the mother empties her bladder at regular intervals during labor to prevent the bladder from becoming an obstruction for labor. Now, when we look at the recording of the blood pressure and the pulse, I think everybody knows how to record the blood pressure and the pulse on a graph like this. The blood pressure has been recorded by little arrows where the systolic pressure is and where the diastolic pressure is connected with the dotted line. And the pulse is being recorded by a dot opposite the pulse rate, like in this case, the pulse rate was 80 beats per minute, and the blood pressure was here 120/60 millimeters mercury. Now, the blood pressure and the pulse, as we've said, very important, should be measured between contractions, because during contractions, if you remember the physiological changes that happen in the maternal body during labor, the moment that the uterus contracts, there's a lot of blood in the uterus because there's an increase of blood flow to the uterus. All the blood flow to the uterus is being cut off by the muscle, the muscle of the uterus the moment that it contracts. And all that blood goes back into the maternal system. And that causes an increase of the cardiac output and therefore also an increase in blood pressure and the pulse. So that's the reason why the blood pressure and the pulse should be taken and measured between contractions to get an accurate measurement of the blood pressure and the pulse. If the blood pressure is abnormal, for example, in the case of hypertensive patients or preeclamptic patients, the blood pressure should be measured more often depending on the condition of the patient. As I've said here, for example, the blood pressure was 120/60 millimeters mercury in this case, and here at 10 o'clock it was 100, here opposite 130/80 millimeters mercury, and the pulse was 100 beats per minute. So if we look more specifically at the pulse, what is very important here is we all know that when the mother is coming to, especially first-time mothers, is coming to the labor ward and the maternity ward, that they are anxious and they don't really know what to expect, etc. So it very often happens that the pulse is higher than normal. But if this pulse persists to be over 100 beats per minute, we should look further for the reason why the pulse is so high, which might be anxiety, as I've said, pain, infection, ketosis, and we will come to ketosis also in more depth, and then obviously also hemorrhage is the one thing that we should definitely look out for when the patient is having a persistent high pulse. So here, for example, as we've said just now, the pulse was 80 beats per minute there and 100 beats per minute there. Now, when we look at the respiratory rate, now normally during labor also the respiratory rate increases. It increases for two reasons. The one is because of pain, but it also increases because of increased oxygen consumption. The mother needs more oxygen during labor because the fetus needs more oxygen during labor, and that makes that the respiratory rate normally is a little bit higher than normal. And it is being recorded here. For example, here you can see that the respiratory rate was 20 respirations per hour, and in this case 22 respirations per hour. And the one important thing that's also, there's not really space and place on the partograph to record that, but is to look out for hyperventilation, and specifically during contractions when the mother really experiences a lot of pain. Then when we look at the temperature, the mother's maternal temperature should be normal during labor. If there's a rise in temperature, it might be an indication of an infection, and one should look further for the place of the infection, if I can call it like that. And then what's also very important is that a rise in temperature accompanied by an increase in the pulse rate might be an indication of maternal dehydration and exhaustion. And if that is accompanied by ketones in the urine, like we can see here, a 37.5 Celsius temperature plus ketones in the urine, then the patient has not passed any urine, so we don't know whether she's dehydrated or not. She has passed 200 milliliters there. But this ketones, together with the increase in temperature, although it's still a normal temperature, might be an indication for us that this patient is suffering from dehydration and ketoacidosis, as I've said. So here in the temperature, how to record the temperature is we just write it in the specific blocks. Now the urine, there are two very important aspects about urine and the recording of the urine on the partograph. And the one is every single sample must be tested for glucose, ketones, protein and blood, because that is very important for us to determine the maternal condition. Glucose specifically in the case of a diabetic patient. Ketones, like we've said earlier, which might be an indication of ketoacidosis, maternal exhaustion, which we should definitely look after. Protein, specifically in the case of mothers with hypertension. Otherwise, the protein might come from the liquor if the membranes have ruptured, or it might also come from the increased mucus secretion because of the mucus plug, this show that's been coming out and being secreted during labor. Blood might be also from the show, if it's not a lot of blood. If there's blood, proper hematuria, blood in the urine, it might be an indication of a uterine rupture, or it might also be an indication of obstructed labor, especially in prolonged labor. We get that the bladder gets damaged because of all these contractions and pressure on the bladder, and we might get blood in the urine. Now, what is very important, if you remember and think about the anatomy of where the bladder sits, it sits right above, in specifically labor, right above the symphysis pubis, and when it's full, it will definitely cause obstruction and might be a reason for a head that's not engaging, for example. So what is very important is to record every time the volume of the urine when the patient passes urine, so that we can see how much urine is being passed. Now here you can see there was 200 milliliters urine, and 4 hours later there's only 100 milliliters urine being passed. Now it obviously depends on whether this patient has drunk some fluids or had an IV infusion on, but we know that 300 milliliters urinary output over 4 hours is too little. So the only conclusion that we can make is that the bladder is full, and in which case, as I've said, it might lead to obstruction of labor. So here we see at this time here, which is 10 o'clock, the patient has passed 200 milliliters of urine and it has been tested and there was no protein, ketones, blood or glucose in the urine. Here, 4 hours later, we saw that the patient has passed 100 milliliters of urine. There is now protein in the urine and ketones in the urine. And now it's very important again to look at the full picture. What's going on with labor? Is labor prolonged? What's the patient's blood pressure? We see that the blood pressure is fairly normal. So in which case we're not too worried about this protein in the urine. And then we have these blocks at the bottom of the partograph where management, the medication and IV fluids are being recorded here and pain management here. So when do we normally give a patient IV fluids? When do we normally put up an IV infusion? In the case of fecal compromise, where we have diagnosed now, for example, an abnormal CTG pattern, we give a bolus of Ringer's lactate, 200 to 300 milliliters intravenously, and continue with an infusion of Ringer's lactate to run over at 120 milliliters per hour. And what we try to do here is to increase the blood flow, literally by increasing the blood volume and blood pressure to the placenta, so that the optimum kind of oxygen transfusion can take place in the placental area. In the case of prolonged labor, when the labor is crossing the alert line, we will do the same. We also start with a bolus of 200 to 300 milliliters intravenously Ringer's lactate, and then we also run it over at 120 milliliters per hour. And the reason for that is basically just also specifically if the mother is dehydrated, and then also if any intervention is necessary, specifically in prolonged labor, we know that there's a big risk of postpartum hemorrhage, for example. So that's why it's very important. And then also in the case of prolonged labor, the mother, as I've said, might become dehydrated and ketoacidotic, and this will also help for that. And that's why I'm saying here, in the management of dehydration and ketoacidosis. And then in all high-risk cases, I think it's always a good principle to put up an IV infusion and to make it run very slowly, so that whenever we need open vein to give any medication, like, for example, syntocinon in the case of a patient that's bleeding, in the case of patients with high blood pressure, to give some intravenous medication, etc., we always have an open vein. So, and in the cases of high-risk patients for postpartum bleeding as well. Then pain management. Now, normally what we only do in this area for pain management is we only record the medication that the patient get for pain management, like, for example, when we give the patient pethidine and atarax, that's where we will record it. But I think it's also very important to record the non-pharmacological management of pain, so that everybody can see what we are doing for this patient. The birthing ball, or put her in a warm bath, and we can see whether there's any effect of it. And we can also see, again, if we look at the total partograph, whether there was any improvement in the progress of labor. And then also whenever we give the sedatives with the analgesic, for example, the atarax or the Phenergan or whatever sedatives we give with atarax. And that brings us to the end of this lesson, and it's quiz time again for you to complete the quiz and test your knowledge. I hope you are going to do well in it. And then I see you in lesson 4.